Before the grant even came into being, we had been focused on trying to make the patient experience seamless throughout our system.
We built a data warehouse, and the data warehouse that we used was an Azara product. It was able to pull data from our electronic medical record, ECW, but also from multiple other databases and other sources of information, and collate all that information into one organized data warehouse that we were then able to apply algorithms and rules to generate reports. One of the things that we did with the data, for example, we built dashboards where a provider, whether it be an attending or to resident, was able to look at all of the patients that they're treating and to get an idea of how they're managing their population. We were moving more and more and helping the residents learn more and more about population management.
We didn't just use the data, we actually put it into a process in which the MAs were involved. If the patient was missing a foot exam, the MA actually would bring a red foot give that to the patient, and the patient would bring that to the provider and remind them the need for a foot exam. We use the same mechanism now for tobacco cessation.
So not only does it begin to help them think about population management, but it also shows where they're not doing well. And you need to understand where you're not doing well so that you could do improvements.
We know which diabetics are truly high-risk diabetics. We know when to intervene. And we know when they are missing a crucial test, and we proactively reach out to them and bring them into care.
Having a diabetic foot exam is essential for diabetics because part of the disease process is neuropathy, in which they no longer have feelings in their foot, so they could have ulcerations there that they were really unaware of.
So the panel management and understanding where you have room for improvement is a very important part of quality and quality training.
Perhaps one of the most important was a program of sepsis simulation training that we did in our simulation lab. And we were able to contract with a company, Medical Simulation Corporation, to come in and periodically do team training with our physician staff, nursing, and respiratory therapists. They would work together as groups doing simulated case scenarios, and that really improved performance, both knowledge base and performance at the bedside.
Prior to the training grant, the residents had a very difficult time going to their ambulatory sites and integrating their primary care training into their overall internal medicine residency. And I think a lot of that related to the dichotomy that existed between the responsibilities on the inpatient floors and the amount of work that they had to do in the ambulatory setting. 4+1 curriculum allowed our residents to have dedicated time to receive didactic education and focus in on ambulatory training. I think it really revolutionized the residency program in that it allowed us to carve out time for things like simulation, for quality improvement projects, and to make some transformative changes in the education process of the entire residency program that we wouldn't have been able to do prior to the DOH grant.
This encapsulated both the hospital and our ambulatory care sites. It was educational. How do you take the main core of what a resident learns? How do you get them to change from just being hospital-focused to treating a population and a panel over time? It taught us that we need to learn how to manage panels of patients from an outpatient perspective, so that physicians had to be accountable for specific patients, that they had to learn how to do chronic diseases over time. It helped us reorganize our labor force so that everyone truly worked at the top of their license.
One of the programs that we've been able to realize we need, and we can only fund through district dollars, is to create a real navigation center, a call center that can reach out to patients, be proactive, and find out what kind of care patients need and reach out to them. But also reactive. Let patients call us at that navigation center and tell us the kind of care they need. Do they need an appointment? Do they need help getting to that appointment? That's what the navigation center is going to do. And we wouldn't even have known that we needed that without the practice that the grant gave us.
Patients need a variety of different resources to navigate our system. So either they're going to get the care by coming to the emergency department and seeking out specialists and different members of the care team as needed, and that care is often uncoordinated and probably not cost effective. Or they can come to a primary care provider who can really serve as the core and guide them to the right specialists, the right therapies, and do it in a way that provides the patient with care that's convenient and effective and also cost efficient.
If you look at the high-risk patient population that we've determined through our algorithm from this project, we've already seen huge reductions in readmissions to the hospital, huge reductions in presentations to the emergency room when they weren't necessary, and better compliance. We seek out those that have no access to health care and give them access to health care.
Me daba por caminar de mañana at 1 o'clock in the morning. Empezaba a caminar y a beber.
Jaime Lopez is a perfect example of how our community case management programs help change people's lives.
Jaime was an alcoholic for many, many years. He was out in the streets. We went out to help him to find a home, to help him to stop drinking, to help him to get his life back in order. The care that he received, he embraced it because everyone embraced him and they wanted to help him.
I stopped drinking, no more drinking. It's good for me.
I'm just elated to be part of the health home, part of being able to reach the patient and embrace them and love them and show them it's okay.
So people's lives were better because they were home, and they were home because they were in better health. And the system saved huge amounts of money because we were able to keep people out of the hospital after they had just gotten out.
I think that there will be a return on investment because what this does is enable an institution like Lutheran to really move into population health. And population health is the future.
And to be able to go forward into a population health setting where people are healthy, where we have care managers in the community, even community outreach workers, so that people can stay home and in their community and not really be called patients anymore, but be called members of the community.
So there's a real incentive to build changes in behavior that will have long-term ramifications because it will save money for the system.